Good morning to our clinical instructors. Ma'am Susan Maglicki, Ma'am Ria Ramos, Ma'am Vanessa Licio, and Ma'am Winfred Leah Bondic.
We are the Group 3, Lay Ann Arceo, Ian Jeb Cobigan, Nicole Ann Innocention, and Bridget Rose Hoyo.
We are going to present case number 4, asthma versus emphysema.
History of present illness. Mrs. H presents to the clinician with a continued complaint of a cough. She reports that she has been feeling increasingly fatigued and breathless on exertion over the past few weeks.
Recently she feels that her health is declining, and she finds that she is able to do less and less. In particular, she finds housework almost impossible, and she has just moved her bedroom to the ground floor as she finds it very difficult to climb stairs. She is having some problems with bathing and dressing, and she finds these to be increasing struggles. She visits her clinician every month for repeat prescriptions and, when needed, follow-up of her hypertension. On review, it is evident that she is experiencing increasing shortness of breath, dyspnea on exertion, difficulty in undertaking household tasks, and disturbed sleep due to coughing. She is also experiencing fatigue and is worried about her capacity to manage her home tasks. History of past illness. Mrs. H had a history of hypertension, and she has been to the clinic 3 times over the last 6 months with the same troublesome cough. She has had 2 chest infections, one of which resulted in an admission to the hospital. She had a hysterectomy 20 years ago and an appendectomy when she was a child. She has an occasional social drinker, and she has a smoking history of 15 to 20 cigarettes per day for 45 years. She stopped smoking 4 years ago.
Hello, for today we will be discussing the pathophysiology of emphysema patient base. First, let us know what is emphysema. Emphysema is a lung condition that causes shortness of breath. In people with emphysema, the air sacs in the lungs, alveoli, are damaged. Risk factors. Modifiable risk factors: cigarette smoking, exposure to radicals. Non-modifiable risk factors includes gender, age, history of lung infection. With the inhalation and exposure of radicals that enters the lungs to the alveolar sac of the alveoli, where macrophages are naturally found, reacts by secreting inflammatory mediators and inflammatory cytokines, mainly interleukin-6, 8, and 1, the tumor necrosis factor alpha and the leukotriene EB4. By any of these inflammatory mediators, chemotaxis occurs. By the way, chemotaxis is the movement of the antibodies to the targeted area. With chemotaxis, neutrophils are promoted. Neutrophils are type of antibodies being activated and secretes protease, mainly elastase, which acts in the destruction of the elastic fiber. Also, with neutrophils, it secretes matrix metalloprotease that is responsible in the damage of the surrounding tissue. Chemotaxis also activates T lymphocytes that is responsible for T-cell mediated apoptosis, is the programmed cell death that will result to tissue destruction and eventually result to fibrosis where there is collagen deposition. And because of the destruction of elastic fiber and presence of fibrosis, protease activity increases while antiprotease decrease, mainly alpha antitrypsin, wherein emphysema develop and progresses. Emphysema, lungs experienced air trapping, wherein the alveoli freely expand forcefully during inhalation and unable to recoil during expiration due to fibrotic tissue of the lungs. Since there is already damage in lungs that impedes gas exchange, patient with emphysema will experience severe coughing, wheezes, shortness of breath, chest tightness, difficulty breathing, increased mucus production, cyanosis, and edema. And that is all about the pathophysiology of emphysema. Thank you.
For the diagnostic procedure. So the patient underwent spirometry test. It is the test used to assess how well your lungs work by measuring how much air you inhale, how much you exhale, and how quickly you exhale. It is used to diagnose asthma, chronic obstructive pulmonary disease, COPD, and other conditions that affect breathing. This is how the procedure done.
Okay, here we go.
Okay.
Yep. Okay, keep going, 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 keep going. Perfect. Okay. Could you focus on inhaling a little more, if possible, and on the other side, exhaling a little longer?
Right.
Okay. Do you want to have a little break, or?
Yes.
Okay. So, you ready?
Yeah.
Perfect. Okay. Let's have another try, and as said before, try to focus on inhaling completely and exhaling to the max. Okay, here we go. Keep going, keep going, keep going, keep going, keep going, keep going. Okay.
It's hard to keep breathing towards the end.
Yeah. Yeah, but this was a nice try.
These are the results of pre-bronchodilator and post-bronchodilator. Results reveal that FEV1-FVC ratio is less than 80%. It means the patient pre- and post-bronchodilator test the predicted percentage of FEV1 value results indicates moderate to severely abnormal. For the drug study. Name of drug Spiriva. It is an anticholinergic bronchodilator. For the dosage, route and frequency, it is administer 500 mcg once daily. The mechanism of action of this drug is an anticholinergic drug used to prevent bronchospasm, narrowing of the airways in the lungs, in people with bronchitis, emphysema, or COPD, chronic obstructive pulmonary disease. It is indicated for the long-term, once-daily, maintenance treatment of bronchospasm associated with chronic obstructive pulmonary disease. Contraindicated to hypersensitivity to tiotropium, ipratropium, or any components of Spiriva capsules. For the side effects. The patient will manifest dry mouth, constipation, cough, and local irritation, tachycardia, difficulty in micturition and urinary retention, hypersensitivity reactions. For the nursing responsibility. Instruct the client on how to use the handy halo properly. Check the vital signs, especially respiratory rate, depth, rhythm, and quality. Do not use more than one capsule for inhalation in a 24-hour period. Instruct the patient that do not swallow these capsules by mouth. Use the special inhaler to inhale the powder in the capsules. Instruct the patient to increase fluid intake. Instruct the patient to rinse her mouth with water immediately after inhalation to prevent mouth or throat dryness or thrush. Instruct the patient to inhale this medication by mouth as directed by your doctor, usually once daily. Instruct the patient to clean the inhaler at least once a month with water. Allow to air dry fully before using again. Name of drug, Seretide. It is corticosteroid, an anti-inflammatory drug. For the dosage, route and frequency, it is given 200 mcg twice daily. For the mechanism of action. Salmeterol protects against symptoms. Fluticasone propionate improves lung function and prevents exacerbations of the condition. It is indicated in the regular treatment of asthma where the use of a combination product is appropriate. It is contraindicated in patients with a history of hypersensitivity to salmeterol shinifoate, fluticasone propionate. For the side effects. These are the side effects of the drug: hoarseness, headache, soreness of the throat or tongue, muscle cramps, and increase in heart rate. For the nursing responsibility. Instruct the client on how to use the inhaler device properly. Next is to monitor rate, depth, the rhythm of respiration. Next is to advise the patient to don't suddenly stop using Seretide. even if you don't currently have any breathing problems unless your doctor tells you otherwise.
Generic name, albuterol. Brand name, Ventolin. Drug classification, bronchodilators. Route and dosage. Orally and 200 mg as needed. Mechanism of action. Albuterol acts on beta-2 adrenergic receptors to relax the bronchial smooth muscle. It also inhibits the release of immediate hypersensitivity mediators from cells, especially mast cells. Although albuterol also affects beta-1 adrenergic receptors, this is minimal and has little effect on the heart rate. Indication: albuterol is used to prevent and treat difficulty breathing, wheezing, shortness of breath, coughing, and chest tightness caused by lung diseases such as asthma and chronic obstructive pulmonary disease, COPD, a group of diseases that affect the lungs and airways. Contraindication: overactive thyroid gland diabetes, a metabolic condition where the body cannot adequately use sugars called ketoacidosis, excess body acid, low amount of potassium in the blood, high blood pressure, diminished blood flow through arteries of the heart. Side effects: nervousness or shakiness, headache, throat or nasal irritation, muscle aches. Nursing responsibility: monitor therapeutic effectiveness, which is indicated by significant subjective improvement in pulmonary function within 60 to 90 minutes after drug administration. Consult physician about giving last albuterol dose several hours before bedtime, if drug-induced insomnia is a problem. Review directions for correct use of medication and inhaler. Avoid contact of inhalation drug with eyes. Do not increase number or frequency of inhalations without advice of physician. Notify physician if albuterol fails to provide relief, because this can signify worsening of pulmonary function and a reevaluation of condition/therapy may be indicated. Note: albuterol can cause dizziness or vertigo. Take necessary precautions. Name of drug: generic name, amlodipine. Brand name, Exforge. Drug classification, calcium channel blocker. Route and dosage: orally in 100 mg once a day. Mechanisms of action: Exforge, amlodipine and valsartan, has been shown to be effective in lowering blood pressure. Both amlodipine and valsartan lower blood pressure by reducing peripheral resistance, but calcium influx blockade and reduction of angiotensin II vasoconstriction are complementary mechanisms. Indication: treatment of essential hypertension. Exforge is indicated in adults whose blood pressure is not adequately controlled on amlodipine or valsartan monotherapy. The recommended dose of Exforge is 1 tablet per day. Contraindication: severe narrowing of the aortic heart valve, significantly low blood pressure, severe liver disease, low amount of sodium in the blood, high levels of potassium in the blood, low levels of a type of white blood cell called neutrophils, renal artery stenosis, low blood pressure. Side effects: tired feeling, nausea, upset stomach, muscle spasms, back pain, stuffy nose, sore throat. Nursing responsibilities: lab tests, monitor liver function tests, BUN and creatinine, serum potassium, and CBC with differential, periodically. Monitor vital signs, especially blood pressure. Notify physician of episodes of dizziness, especially those that occur when making position changes. Give on an empty stomach. Correct volume depletion prior to initiation of therapy to prevent hypotension. Reduce dosage with severe hepatic or renal impairment. Medical management/treatment. Intravenous fluid of 0.9% sodium chloride, 1 liter regulated at 21 gTts per minute to infuse for 12 hours at the dorsal metacarpal vein of the left hand using a gauge 22 intravenous catheter. Date performed/changed/discontinue. July 15, 2021. General description. Normal saline is a prescription medicine used for fluid and electrolyte replenishment for intravenous administration. It is an isotonic solution that is a mixture of salt and water. Indication/purpose. This solution is used to restore and replace body fluid losses. Client reaction to treatment. The client tolerated the administration of intravenous fluid without any complications such as infiltration, phlebitis or skin irritations. Nursing responsibility. Check the doctor's order. Report any abnormal symptoms observed immediately. Do not administer unless solution is clear and container is undamaged. Properly label the fourth fluid. Observe aseptic technique when changing for fluid. Medical management/treatment. Oxygen therapy via nasal cannula regulated at 2 to 3 liters per minute. Date performed/changed/discontinue. July 15, 2021. General description. Oxygen therapy is a treatment that provides supplemental or extra oxygen. It may be given through a nose tube or a mask. Indication/purpose. This therapy good due to shortness PF breath and an increased respiratory rate of 25 cpm. Client reaction to treatment. The client tolerated the therapy and shortness PF breath was addressed. Verify client's identity by asking the name and date of birth. Check the doctor's order for the initiation of the therapy. Check the oxygen cylinder for the accessories and working condition. Check frequently that the both prongs are in client nares. Observe the client nose and superior surface of both ears and skin for mucosal dryness and skin irritation. Be sure that the client has no matches, cigarettes or smoking materials in the bedside table.
For the objective data, there is a presence of shortness of breath to the patient. Dyspnea on exertion. With the oxygen saturation of 90% following exertion. Productive cough with a clear and forthy sputum. And there is hyperinflation of the chest and some use of accessory muscles of respirations. And abnormal breath sounds of wheezing and crackles. And for the vital signs. Blood pressure of 164/92 mm of mercury, pulse rate of 110 beats per minute. Respiratory rate of 25 breaths per minute and a temperature of 36.9 degrees Celsius. And her oxygen saturation levels are 93% dropping to 90% following exertion. And for the nursing diagnosis of the patient. For the planning. And for the nursing intervention. Number 1. Assess the patency of airway of the patient. Maintaining patent airway is always the first priority, especially in cardiac arrest. Auscultate lungs for presence of normal or adventitious breath sounds. Abnormal breath sounds can be heard as fluid and mucus accumulate. This may indicate ineffective airway clearance. Number 3. Assess respirations. Note quality rate pattern depth flaring of nostrils, dyspnea on exertion, evidence of splinting, use of accessory muscles and position for breathing. A change in the usual respiration may mean respiratory compromise. An increase in respiratory rate and rhythm may be a compensatory response to airways obstruction. Number 4. Note for changes in heart rate, blood pressure, and temperature. Increased work of breathing can lead to tachycardia and hypertension. Number 5. Note cough for efficacy and productivity. And note presence of sputum, evaluate its quality, color and consistency. Increased work of breathing can lead to tachycardia and hypertension. And retained or atelectasis may be sign of an existing infection manifested by a fever or increased temperature. And coughing is mechanism for clearing secretions. An ineffective cough compromises airway clearance and prevents mucus from being expelled. Number 6. Submit a sputum specimen for culture and sensitivity testing as appropriate. Labored breathing may be a sign of respiratory infection that needs an appropriate treatment of antibiotics. Number 7. Use pulse oximetry to monitor oxygen saturation to assess arterial blood gases. Pulse oximeter is used to detect changes in oxygen. Oxygen should be maintained at 90% or greater. Alteration in ABGGs may result in increased pulmonary secretions and respiratory fatigue. Number 8. Assess hydration status. The skin, turgor, mucous membranes and tongue. Airway clearance is impaired with poor hydration and subsequent secretion thickening. Number 9. Position the patient upright. If tolerated, then regularly check the patient's position to prevent falling. This position promotes better lung expansion and improved air exchanger. Number 10. Perform nasotracheal suctioning as necessary, especially if cough is ineffective. Suctioning is needed when patients are unable to cough out secretions properly due to weakness, thick mucus plugs, or excessive or tenacious mucus production. Encourage patient to increase fluid intake to 2 liters per day within the limits of cardiac reserve and renal function. Fluids help minimize mucosal drying and maximize ciliary action to move secretions. Number 12. Provide oral care to the patient. Oral care freshens the mouth after respiratory secretions have been expectorated. Number 13. Maintain planned rest periods, and promote energy conservation methods. Because fatigue is a contributing factor to ineffective coughing. For the dependent nursing interventions, maintain humidified as prescribed. Increasing humidity of inspired air will reduce thickness of secretions, and aid their removal. Give medications as prescribed. A variety of medications are prepared to manage specific problems. Most promote clearance of airway secretions and airway resistance, and provide patient understanding about the proper use of prescribed medications and inhalers. And for the collaborative nursing intervention, coordinate with a respiratory therapist. Chest physiotherapy includes the techniques of postural drainage and chest percussion to mobilize secretions from smaller airways that cannot be eliminated by means of coughing or suctioning. For the assessment. For the subjective data. Objective data of the patient. The patient experiencing increasing shortness of breath. There is hyperinflation of the chest, some use of accessory muscles of respiration, crackles, and an occasional audible wheeze. Productive cough, with a clear and frothy sputum. There is a presence of cyanosis. Her skin is dry and intact, and there is some dehydration evident. Her mouth is dry, oral mucosa is spotted with possible thrush present. The patient experiencing weakness, limited movement and reduced tolerance for activities. And for the vital signs, blood pressure of 164/92 mm of mercury, pulse rate of 119 beats per minute, and respiratory rate of 25 counts per minute. She is afebrile with a temperature of 36.9 degrees Celsius. She appears breathless on exertion. Her oxygen saturation levels are 93%, dropping to 90% following exertion. And for the nursing diagnosis, nursing intervention. Assess and record respiratory rate and depth. Note the use of accessory muscles, pursed lip breathing, inability to speak or converse. Useful in evaluating the degree of respiratory distress or chronicity of the disease process. Assess and routinely monitor skin and mucous membrane color. Cyanosis may be peripheral, noted in nail beds, or central, noted around lips/or earlobes. Duskiness and central cyanosis indicate advanced hypoxemia. Monitor changes in the level of consciousness and mental status. Restlessness, agitation, and anxiety are common manifestations of hypoxia. Worsening ABGs accompanied by confusion somnolence are indicative of cerebral dysfunction due to hypoxemia. Monitor vital signs and cardiac rhythm. Tachycardia, dysrhythmias, and changes in BP can reflect the effect of systemic hypoxemia on cardiac function. Auscultate breath sounds, noting areas of decreased airflow and adventitious sounds. Breath sounds may be faint because of decreased airflow or areas of consolidation. Presence of wheezes may indicate bronchospasm or retained secretions. Scattered moist crackles may indicate interstitial fluid or cardiac decompensation. Monitor oxygen saturation and titrate oxygen to maintain oxygen saturation between 88% to 92%. Pulse oximetry reading of 87% below may indicate the need for oxygen administration, while a pulse oximetry reading of 92% or higher may require oxygen titration. Encourage expectoration of sputum, suction when needed. Thick, tenacious, copious secretions are a major source of impaired gas exchange in small airways. Deep suctioning may be required when the cough is ineffective for expectoration of secretions. Elevate the head of the bed, assist the patient to assume a position to ease work of breathing. Include periods of time in a prone position as tolerated. Encourage deep, slow or pursed lip breathing as individually needed or tolerated. Oxygen delivery may be improved by upright position and breathing exercises to decrease airway collapse, dyspnea, and work of breathing. Use of prone position to increase POW2. Evaluate the level of activity tolerance. Provide a calm, quiet environment. Limit patient's activity or encourage bed or chair rest during the acute phase. Have patient resume activity gradually and increase as individually tolerated. Rest interspersed with care activities remains an important part of the treatment regimen. Evaluate sleep patterns, note reports of difficulties and whether patient feels well rested. Provide quiet environment, group care or monitoring activities to allow periods of uninterrupted sleep. Limit stimulants such as caffeine. Encourage position of comfort. Multiple external stimuli and the presence of dyspnea may prevent relaxation and inhibit sleep. And for the dependent nursing intervention, provide humidified oxygen as ordered. Administering humidified oxygen prevents drying out the airways, decreases convective moisture losses, and improves compliance. Administer non-invasive positive pressure ventilation as ordered. The use of non-invasive positive pressure ventilation can decrease partial pressure of carbon dioxide, increase blood pH, and minimize symptoms of severe dyspnea during the first 4 hours of the treatment. For short-term goal, after 2 to 3 hours of nursing intervention, the patient was able to demonstrate improved ventilation and adequate oxygenation of tissues. And for the long-term goal, after 1 to 2 days of nursing intervention, the patient was able to maintain proper ventilation and adequate oxygenation of tissues within patient's normal range. The goal was met. For the assessment, subjective data, and for the objectives, the patient experiencing shortness of breath and dyspnea on exertion. There is hyperinflation of the chest, some use of accessory muscles of respiration, crackles, and an occasional audible wheeze. Presence of productive cough and it is clear and frothy sputum. And for the vital signs, for the blood pressure of 164/92 mm of mercury, pulse rate of 119 beats per minute, respiratory rate of 25 counts per minute, and temperature of 36.9 degrees Celsius. And for the oxygen saturation levels are 93%, dropping to 90% following exertion. And for the nursing diagnosis, for the planning, and for the nursing intervention. Assess patient's respiratory status every 2 to 4 hours as indicated and notify any abnormal findings. Manifestation of respiratory distress includes shortness of breath, tachypnea, changes in mental status and the use of accessory muscles. Auscultate breath sounds every 2 to 4 hours as indicated. Decreased breath sounds, crackles, wheezes, and rhonchi can be observed and must be reported promptly for immediate treatment. Place a pillow when the client is sleeping. It provides adequate lung expansion while sleeping. Instruct how to splint the chest wall with a pillow for comfort during coughing and elevation of head over the body as appropriate. Promotes physiological ease of maximal inspiration. Maintain a patent airway, suctioning of secretions may be done as ordered. Provide respiratory support. Oxygen inhalation is given as ordered, aid in relieving the patient from dyspnea. Administer medications as ordered. And for the evaluation. Short-term goal. After 3 to 5 hours of nursing intervention, the patient was able to improve breathing pattern and maintain a respiratory rate with normal limits. And for the long-term goal. After 1 to 3 days of nursing intervention, the patient was able to establish effective respiratory pattern.
Thank you for listening.